Good morning, everyone. Myself, Dr. Aswina Sundari, Senior Resident Faculty in Department of Respiratory Medicine in Sri Lakshminarayana Institute of Medical Sciences, Pondicherry. Today, we'll discuss about anatomy and physiology of respiratory diseases and pneumothorax. So, first we'll see about anatomy and physiology of respiratory diseases. So, under anatomy, we'll discuss about tracheobronchial tree, interstitium, blood supply, lymphatic drainage, innervation, anatomic divisions of lung. So anatomy of respiratory system, we know divided into upper and lower respiratory tract. So upper respiratory tract extends from nose to larynx. So it includes nose, nasal cavity, paranasal sinuses, pharynx and larynx. Lower respiratory tract extends from trachea to the alveoli. So it includes trachea, bronchi and bronchioles, lungs and alveoli. So the lungs reside in the pleural cavities, which is the subdivision of the thoracic cavity. So here the lung is lined by the visceral pleura. The thoracic wall is lined by the parietal pleura. So in between the parietal and visceral pleura, there is the intrapleural space, which is the pleural cavity containing pleural fluid. So these are the respiratory pressures during a breathing cycle. So the picture A is showing the end expiration. The end expiration, the pleural pressure is -5. And the other pressure, airway opening pressure and alveolar pressure are 0. The picture B is during inspiration. The pleural pressure will become further negative, -8. The airway opening pressure is 0. The alveolar pressure is -2. At the end of inspiration, the picture C is showing pleural pressure -10. That is more negative pleural pressure. So why all this happening, we'll see. So the normal intrapleural pressure at the end exhalation is -5, which become more negative during inspiration, -8. So why it means due to the action of inspiratory muscles, which results in inspiring air from the atmosphere. The more negative pressure, it's like a suctioning effect. The more air withdrawn from the atmosphere. That's how the inspiration is happening. It is an active process which happens due to action of inspiratory muscles. The expiration is a passive process, during which respiratory muscles are relaxed. So which make the intrapleural pressure less negative and air is expelled out. So the inspiration active process, expiration is a passive process. Here no respiratory muscles are going to act. So the intrapleural pressure becoming less negative, which make the air to go out. So what are the applied aspects here? In pneumothorax and pleural effusion, the pleural pressure will become positive due to accumulation of air and water respectively. So a normal lung pleural pressure is negative. In pathology lung, pleural effusion and pneumothorax, pleural pressure become positive. So this results in collapse of the lung as there is inspiration not happening now. So also it results in ventilation perfusion mismatch, VQ mismatch, which result in hypoxemia. So there are 23 generation of airways. Airways 0 is trachea, bronchi is 1, 2, 3. From bronchioles, it extends from 4 to 14 as terminal bronchiole. Generation 15 is transitional bronchiole. 16 to 18 is respiratory bronchiole. 19 to 22 is alveolar duct. And 23 is alveolar sac. Here the generation 0 to 14 are known as conducting airways. From the trachea to the terminal bronchiole. From the respiratory bronchiole, generation 16 to the alveolar sac, generation 23 are Aswina airways. So what are the applied aspects here? We know chronic bronchitis. Chronic bronchitis is enlargement of mucous gland in airway, mucus hypersecretion, which lead to airway obstruction. So this involves the generation airway is bronchi. On the other one, asthma. Asthma is known as airway inflammation and remodeling, which means airway wall thickening, smooth muscle hypertrophy happening, which result in bronchoconstriction and airway obstruction. So what is acinas? Acinas is a parenchymal unit in which all airways have alveoli attached in their wall and participate in gas exchange. So this is an electron micrograph of a acinus of a human lung. So here you can see the respiratory bronchiole, transitional bronchioles, alveolar duct and alveolar sac. So the alveolus look like a foam-like structure. So this picture shows the branching pattern of the airways and the vessels. So trachea divide and it form and it end in the alveoli. Likewise, the pulmonary vessels also divide. Pulmonary arteries will divide it into arterioles and it form capillaries around the alveoli. So here it is seen more clear the alveolar capillary network. The pulmonary capillaries and the alveoli are together forming the alveolar capillary network. The pulmonary veins also branch along with the pulmonary arteries and the airways. So what is lung parenchyma or interstitium? It comprises gas exchanging airways, vessels and connective tissue framework. Pulmonary interstitium is a collection of support tissues within the lung, which includes alveolar epithelium, pulmonary capillary endothelium, basement membrane, perivascular and perilymphatic tissues. So the interstitium is divided as axial and peripheral interstitium. Axial interstitium include peribronchoscular interstitium and centrilobular interstitium. Peripheral interstitium include subpleural interstitium and intralobular interstitium. So the lobules are separated by the interlobular septa. So this picture shows the alveolar capillary membrane. The alveoli is lined by the alveolar epithelial cell. Type 1 alveolar cell, type 2 alveolar cell, and the surfactant layer lining the alveoli. The surfactant is stored in lamellar bodies, which is also seen here. So the airway has the epithelial basement membrane. So next is the pulmonary capillary. The capillary is lined by the endothelium. Here the endothelium basement membrane also present. Also the red blood cells, platelets also present. So in between the alveoli and capillary is the interstitium. This interstitium contains the fibroblast. So here the exchange of gases is happening. The oxygen will diffuse from alveoli into the pulmonary capillary and the carbon dioxide will diffuse from pulmonary capillary to the alveoli. Surfactant important function is that reduces the surface tension of the alveolar lining fluid, thereby prevent the alveolar collapse at the end expiration. Type 1 alveolar epithelial cell form the 97% of the alveolar surface area, which is involved also in the alveolar and ion and fluid homeostasis. Type 2 alveolar epithelial cells regenerate the type 1 cells in lung injury, which will happen within 2 to 5 days. So the type 2 cells secrete the surfactant, which is important to prevent the alveolar collapse. So applied aspect is the interstitial lung disease. So interstitial lung disease are the restrictive lung disease with reduced lung volumes and impaired lung diffusion capacity. So as the alveolar capillary membrane is affected, diffusion of gases will be impaired, which will result in hypoxemia and hypercapnia. So what is the blood supply of lung? Lungs have a dual blood supply. Bronchial circulation comprising of bronchial arteries and veins, and pulmonary circulation comprising of pulmonary arteries and veins. Pulmonary arteries, right and left pulmonary artery originate from the pulmonary trunk and carry deoxygenated blood to the lungs from the right ventricle of the heart. The bifurcation of the pulmonary trunk occur left to the midline, just inferior to the vertebral level of T4 and T5 and anterior inferiorly to the left of bifurcation of the trachea. So pulmonary veins on each side, a superior pulmonary vein and inferior pulmonary vein carry oxygenated blood from the lungs back to the heart. So the right lung has 2 pulmonary veins, left lung has 2 pulmonary veins. The 4 pulmonary veins will begin at the hilum of the lung, pass through the root of the lung and immediately drain into the left atrium. So we'll see next about the bronchial circulation. Bronchial arteries, there are 1 right and 2 left artery. Right bronchial artery normally arises from 3rd posterior intercostal artery, but occasionally it can originate from the upper left bronchial artery. Left bronchial arteries arise directly from the anterior surface of the thoracic aorta. Superior left bronchial artery arises at vertebral level T5 and the inferior one inferior to the level of left bronchus. The bronchial veins drain into either into the pulmonary veins or the left atrium or into the azygous vein on the right or into the superior intercostal vein or hemiazygous vein on the left. So the bronchial arteries and veins, this constitute the nutritive vascular system of the pulmonary tissue. Means it supply the bronchial wall and gland, wall of large vessels and visceral pleura. They interconnect within the lung with branches of the pulmonary arteries and the veins. Bronchial arteries extend till most the level of peripheral bronchi only. Here the applied aspect is pulmonary embolism. A infarct seen mostly in the periphery of the lung. It's not seen usually in the center of the lung. Because of the anastomotic presence of collateral circulation between the pulmonary and bronchial circulation till the level of peripheral bronchi. So only the infarct seen in the periphery, not in the center of the lung. So what are the differences between this bronchial and pulmonary circulation? Bronchial arteries supply oxygenated blood pumped from the left ventricle. Systemic circulation, so it is. So it has high pressure and relatively smaller diameter circulation. Pulmonary arteries supply deoxygenated blood pumped from the right ventricle. This circulation is relatively a larger diameter, lower pressure circulation. So what is the lymphatic drainage of lung? Lymphatics of lung drain finally into the systemic venous system at the junction of subclavian and internal jugular vein. So it occurs via the thoracic duct on the left side, right lymphatic duct on the right side. Innervation of lung. So the lung has parasympathetic nerve supply from vagus nerve, which mediate the bronchoconstriction, pulmonary vasodilatation, and bronchial gland secretion. The sympathetic nerve supply from the cervical and upper thoracic ganglia, which is T2 to T4, and it has no functional significance. So what are the anatomic divisions of lung? So right lung has 3 lobes, left lung has 2 lobes. Right lung has 2 fissures, left lung has 1 fissure. So the right lung has horizontal fissure which separate the upper and middle lobe, and the oblique fissure which separate the middle and the lower lobe. In the left lung, the upper lobe with the lingula is separated from the lower lobe by the oblique fissure. Bronchopulmonary segments. The bronchopulmonary segments are the anatomic, structural and functional unit of lung parenchyma, which is each ventilated by a segmental or tertiary bronchus. So right lung has 10 segments, left lung has 9 segments. Right lung upper lobe has apical, posterior and anterior segment, middle lobe has lateral and medial segment, lower lobe has superior, medial basal, anterior basal, lateral basal, posterior basal segment. In left lung, the upper lobe has apico-posterior and anterior, and the lingula has superior and inferior lingula. The lower lobe has superior, anterior basal, lateral basal, posterior basal. No mediobasal segment in the left lung. So this picture shows the all bronchopulmonary segments in the lung. The right and left lung and all 3 lobes, right upper and middle and lower lobe, left upper and with lingula and lower lobe. So what are the main characteristics of a bronchopulmonary segment? It is a subdivision of a lung lobe. It is pyramid shaped with its apex towards the lung root. It is surrounded by the connective tissue. It has a segmental bronchus, segmental artery and lymph vessels and autonomic nerves. The segmental vein lies in the connective tissue between the adjacent bronchopulmonary segment. Because it is a structural unit, a diseased segment can be removed surgically. So what are the applied aspects of the bronchopulmonary segments? So TB, tuberculosis is most common in apical and posterior segment of the upper lobe because of high ventilation and perfusion ratio with elevated alveolar PO2 relative to other zone. Sequestration of lung, most common in the left lung, posterior basal segment of the lower lobe. Any cancerous lesion, more common in the anterior segment of the right upper lobe. Lung abscess, posterior segment of the upper lobe or in the superior or posterior basal segment of the lower lobe, especially on the right lung, it is more common because of the more vertical right mainstem bronchus, and also that the aspirated secretion tend to gravitate in the segment in the supine portion because of this more vertical right bronchus. Aspiration pneumonia more common in apical segment of both lower lobe or posterior segment of the right upper lobe. Bronchiectasis more common in the left lower lobe because of the longer and narrower bronchus leading to the retained secretions. So this is all about anatomy of the respiratory system. Next we will discuss about physiology of the respiratory system. Under this we will discuss about compliance, ventilation perfusion ratio, diffusion, oxygen hemoglobin dissociation curve. So what is the definition of compliance? Compliance means distensibility. It is the ratio of change in lung volume to the change in transpulmonary pressure. So C is the compliance, which is equal to del BL by del pleural pressure minus alveolar pressure and the pleural pressure changes. So here C is the lung compliance, alveolar pressure minus pleural pressure, which is the change in transpulmonary pressure, and del VL is the changes in lung volume. It is the ratio of change in lung volume to the change in lung pressures. So this compliance depend on some elastic behavior of the lung. So the elastic behavior of the lung depend on two factors, which is the surface tension of the film lining the alveolar wall, that is the released by the surfactant, and the physical properties of the lung tissue. So the physical properties of lung tissue is contributed by many things. So a number of the different tissue components contribute to this lung elasticity, which include pleura, intralobular septa, peripheral airway smooth muscle tone, pulmonary vasomotor tone, and the tissue of the alveolar walls, which is majority or consist of collagen and elastin. So the applied aspect here is pulmonary compliance can be increased because of the destruction of the alveolar wall, and which lead to the enlargement of alveolar spaces, which characterize the pulmonary emphysema. So emphysema is nothing but the destruction of alveolar wall, which contain the elastin tissue. So thereby the compliance will get increased. In contrast, the distensibility of lung will be reduced by the pulmonary fibrosis, which stiffen interstitial tissue. There will be more deposition of collagen. There will be the distensibility of the lung is reduced. So the alteration in the elastin and collagen fiber in the lung, that is the compliance distensibility of the lung, will be increases with age. This is a contradictory thing. This is a part of the normal aging process. Compliance increases with aging. So in any acute lung injury, any surfactant suspension will be happen. So it will lead to increase in surface tension. It will lead to stiffening and instability of the alveoli. Thereby it results in the alveolar collapse. So now we can understand the mechanism behind the collapse of alveoli in acute lung injury. This is due to the compliance pathology, compliance getting decreased. So the elastic properties of the chest wall. Like the lung, the elastic recoil of chest wall is, if it were unopposed by the lung, the chest can enlarge approximately to 70% of the total lung capacity. This position represents the equilibrium or the resting position. So here the applied aspects of disorders affecting the chest wall, which means example marker obesity, kyphoscoliosis, and ankylosing spondylitis. So ventilation dead space, the space that contains the volume of air that does not undergo gas exchange with the blood in the pulmonary capillaries. This is known as dead space. So the dead space will be filled with inhaled air at the end of inspiration and with alveolar air at the end of expiration. The volume of air in the dead space is 150 ml. There are two types of dead space, anatomical dead space and alveolar dead space. Anatomical dead space is the conducting zone of the respiratory tract. Alveolar dead space is the non-perfused alveoli. Physiological dead space means anatomical dead space plus alveolar dead space. In normal subject, anatomical dead space will be equal to the physiological dead space because as there is no non-functional alveoli. In disease subject, physiological dead space will be more than the anatomical dead space. Ventilation perfusion ratio. It is the ratio of alveolar ventilation to the blood flow in the lung. In normal individual at rest, the alveolar ventilation is 4 liters per minute and pulmonary blood flow is 5 liters per minute. The normal ventilation perfusion ratio is, that is the V by Q is 0.8. So here we are comparing the ventilation and perfusion in apex, mid and base of the lung. The apex of the lung, zone 1, the ventilation will be poor. The pleural pressure will be higher, the alveoli will be larger and it are less compliant alveoli. In zone 2, mid of the lung, ventilation is normal. In base of the lung, there will be a moderate ventilation, small alveoli, more compliant alveoli. In perfusion, zone 1 apex, poor perfusion, dead space. In zone 2, perfusion is normal. In zone 3 base, the base of the lung, the perfusion is high because of the distended veins. So here we are clear, the perfusion will be more in the base of the lung. So there is a normal ventilation perfusion variation physiologically within the lung from the apex, mid to base of the lung. So effect of ventilation perfusion inequality on overall gas exchange. So this ventilation perfusion ratio is found as 0.8 is normal. It can be 0, it can be high, it can be low in different pathologies. So where it will happen, we'll see discuss. In 0 VQ ratio, it will happen in pulmonary shunt. Pulmonary shunt is no ventilation but perfusion remain normal. So the causes for 0 VQ are alveolar flooding found in pneumonia and ARDS, that is acute respiratory distress syndrome, complete obstruction of airway, extensive compression of alveoli, present in compression atelectasis due to hydrothorax or pneumothorax. So in all these conditions, there will be low VQ pulmonary shunt happening. 0 VQ and pulmonary shunt happening. In low VQ, that is V by Q ratio less than 1 is low ventilation relative to perfusion, such as impartial obstruction of airway. So here some ventilation happening but is incomplete. In 0 VQ shunt, no ventilation happening, only perfusion. In low VQ, less ventilation happening compared to the perfusion. So the causes for low VQ are low compliance, such as in pulmonary fibrosis and the lack of surfactant, or due to high airway resistance found in asthma and COPD. High VQ ratio more than 1. Here the ventilation is normal but the perfusion is abnormal. Low perfusion relative to its ventilation. The causes for high VQ are hypotensive states or a partial obstruction of pulmonary blood vessels present in pulmonary embolism, which may be responsible for the high VQ. Diffusion. So the factors that affect the rate of gas diffusion through the respiratory membrane are the thickness of the membrane, the surface area of the membrane, the diffusion coefficient of gas in the substance of the membrane, the partial pressure difference of the gas between the two sides of the membrane. So we will discuss in detail about each. Thickness. The rate of diffusion through the membrane is inversely proportional to the thickness of the membrane. So any factor that increases the thickness to more than 2 or 3 times than the normal can interfere with normal respiratory exchange of gases. Example, some pulmonary disease which cause fibrosis of the lung, which can increase the thickness of some portion of the respiratory membrane. Pulmonary edema, which is the fluid in the interstitial space of the membrane and in the alveoli. So the respiratory gases must then diffuse not only through the membrane but also through the fluid. So whenever the thickness of the membrane get increased, the diffusion of gases affected. We have the example we have seen in pulmonary fibrosis and the edema. Surface area. The surface area of the membrane can be greatly decreased by many conditions. Removal of the entire lung decreases the total surface area to 1/2 of the normal. Emphysema. Many of the alveolar collapse with dissolution of the many alveolar walls. So in this condition, the surface area of the membrane available for diffusion will be decreased, thereby the diffusion is impaired. Diffusion coefficient depends on the gas solubility in the membrane, square root of the gas molecular velocity, which is inversely proportional. So normally the carbon dioxide diffuses about 20 times as rapidly as the oxygen. Oxygen diffuses about twice as rapidly as nitrogen. Partial pressure gradient. When the partial pressure of a gas in the alveoli is greater than the partial pressure of the gas in the blood, as it is true for oxygen, net diffusion from the alveoli into the blood occurs. When the pressure of the gas in the blood is greater than the partial pressure in the alveoli, as is true for carbon dioxide, net diffusion from the blood into the alveoli occurs. So this picture showing clearly. Here the partial pressure of oxygen in alveoli is 100. In blood it is 40. So oxygen get diffused from the alveoli into the pulmonary capillary. Whereas for carbon dioxide, the partial pressure in capillary is 45 and in the alveoli it is 40. So it diffuses from the pulmonary capillary into the alveoli. From higher to lower concentration gradient. So here next is the oxyhemoglobin dissociation curve. So in this curve, relates the relationship between the partial pressure of the oxygen and the oxygen content in the blood. So this is a sigmoid S-shaped curve as we are seeing. So the plateau part of the curve shows after the PO2 60 to 100, the curve remains the plateau. When the PO2 is between 20 to 60, there is a steep fall in the curve. And the P50 is the partial pressure of oxygen at which the hemoglobin is 50% saturated with oxygen. So here the P50 is 26.5 millimeter mercury. So the total oxygen content of the blood as a function of the partial pressure of oxygen is indicated by the red line. The blue line indicates the content of dissolved oxygen resulting from the changes in PO2. So the flatness of the curve allows for a normal arterial oxygen content as long as the arterial PO2 remain greater than or equal to 60 millimeter mercury. So as long as the PO2 is more than 60, the saturation of oxygen can be maintained as normal. The steep slope between 20 to 60 millimeter mercury of PO2 indicate it facilitates release of large amount of oxygen to tissue with moderate decrease in oxygen tension. So whenever the PO2 will get decreased, there will be more amount of oxygen released into tissue. There will be desaturation of hemoglobin happening. So this picture shows the right and left shift of the oxygen dissociation curve. So the blue curve indicates the curve shifted to the left side, which means the increased affinity of oxygen on the hemoglobin happening. So it will happen in decreased blood hydrogen ion concentration, decreased carbon dioxide, decreased 2,3 dPg concentration, or decreased temperature. The green curve indicates the curve is shifted to the right, which indicate decreased oxygen affinity for the hemoglobin. This will happen in increased hydrogen ion concentration, increased carbon dioxide, increased 2,3 dPg, and increased temperature. So we have seen about anatomy and physiology of respiratory diseases. Next we will discuss about pneumothorax. So what is pneumothorax? Pneumothorax is presence of air in the pleural space. So it can be spontaneous result of iatrogenic injury or trauma to the lung or the chest wall. So classification of pneumothorax. Spontaneous pneumothorax, it is classified as primary and secondary. Primary spontaneous pneumothorax is there is no evidence of any pre-existing lung disease. It occurs mostly in males aged 15 to 30 years. So air escapes from the lung into the pleural space through a rupture of small emphysematous bulla or the pleural bulb. So this is more common seen in smoking, tall stature, and the presence of apical subpleural bulb or the additional risk factors. Secondary spontaneous pneumothorax occur when there is an underlying lung disease. It occurs mainly in males above 55 years of age. It's more common in COPD or TB patient. It's also seen in asthma, lung abscess, bronchogenic carcinoma. Traumatic pneumothorax is secondary that happens to any iatrogenic, thoracic surgery or biopsy or chest wall injury. So what are the types of pneumothorax? Closed spontaneous pneumothorax, open spontaneous pneumothorax, and tension pneumothorax. Closed type pneumothorax is when air or gas gets in the pleural space without any outside wound. There is a communication between airway and the pleural space, which seal off as the lung deflates. There will be a spontaneous reabsorption of air and re-expansion of lung, which can occur over a few days or weeks. Here the infection is uncommon. Open type pneumothorax. Open pneumothorax is when air gets into the pleural space from an injury towards chest. This can happen with stab wound, like from a knife. It can also happen after a gunshot injury. Communication failed to seal and air continued to transfer freely between the lung and the pleural space through a bronchopleural fistula. Infection can be transmitted here, leading to the empyema. Empyema is the first collection in the pleural space. Tension type. Tension pneumothorax is progressive buildup of air within the pleural space, usually due to a lung laceration, which allow air to escape into the pleural space but not to return. There is a communication between airway and the pleural space, which act as a one-way valve, allowing air to enter the pleural space during inspiration but not to escape on expiration, which lead to a large amount of air accumulating progressively in the pleural space. Pressure causes mediastinal shift towards the opposite side with compression of the opposite lung and impairment of systemic venous return, causing cardiovascular compromise. So this picture showing all the type of pneumothorax, closed, open and tension pneumothorax. In closed pneumothorax, the pleural cavity pressure will be less than the atmospheric pressure. In open type pneumothorax, the pleural cavity pressure will be equal to the atmospheric pressure. In tension type pneumothorax, the pleural cavity pressure will be more than the atmospheric pressure. So what are the clinical features of pneumothorax? There will be a sudden onset of unilateral pleuritic chest pain. There will be a breathlessness. In patient with a small pneumothorax, physical examination may be normal. This pleuritic chest pain, it will be sharp, it will be pinpricking, the patient will tell like it will aggravated with deep inspiration and it will be won't be referring or radiating mostly. It will be localized. And breathlessness, it will be a sudden onset of breathlessness patient will tell, which is progressive. It will be, the duration will be mostly within some days. The complaint will be days and it will be progressive, which will make the patient to come to hospital immediately. In general examination, if it is a tension type pneumothorax and if the circulation has become compromised, the patient can be present with cyanosis, rapid deep pulse, signs of peripheral circulatory failure in severe cases. There can be a hypotension also. So in inspection and palpation, since the patient has breathlessness, we can see the use of accessory muscles of respiration. There will be shift of mediastinum to the opposite side. There will be fullness of chest on the affected side. There will be diminished chest movements on the affected side. There will be marked diminished vocal fremitus on the affected side. There will be diminished expansion of the affected hemothorax. And in percussion, there will be hyperresonant on the affected hemithorax side. There will be right sided pneumothorax. Liver dullness is obliterated and cardiac dullness is shifted to the opposite side. In auscultation, there can be diminished to absent breath sounds. There will be absence of any other added sounds. There will be decreased vocal resonance. Investigations. Chest X-ray, it will show the increased radiolucency with absence of bronchovascular markings. There will be a mediastinal shift if it is tension type pneumothorax. There can be a pleural flow defect present due to the acute collapse of the lung. There will be the underlying pulmonary disease if it is a secondary spontaneous type pneumothorax, as we already discussed, COPD, carcinoma, lung abscess, anything can be present, and the costophrenic angus can be cleared if there is no occlusion. Care must be taken to differentiate between a large pre-existing bulla and a pneumothorax to avoid misdirected attempts at aspiration. So, if we may need a CT chest if the patient comes as history of some COPD and he can have a bulla emphysema and he can present with the pneumothorax symptom. So, to avoid aspiration, to avoid confusion, we may need a CT at that time. So, this X-ray shows the pneumothorax. There is a hyperlucency without any vascular marking seen in the right lung. And there is a white line visible, which is the pleural white line, which is the visceral pleural line, which is the collapsed lung border line. The lung is collapsed towards the hilum of the lung, and this X-ray shows the right pneumothorax. So as I told, CT help to differentiate between large pre-existing emphysematous bulla and the pneumothorax. Thereby, it can prevent management, ICD, intercostal drainage, and it will decide the decisions. So CT helps to differentiate between bulla and pneumothorax. So what is the treatment? Treatment, if it is a primary pneumothorax, if the lung edge is less than 2 cm from the chest wall and the patient is not breathless, then it resolves normally without any intervention. The patient having severe symptoms, then percutaneous needle aspiration can be carried out. If it fails, then intercostal tube drainage is done. So first we have to observe the patient. We have to see the vital saturation, everything. Whether it is stable or it is deteriorating, we have to see. Depend on that, the management decision will be taken. Whether to patient will need continuous observation or it may need aspiration or it need intercostal tube drainage. So this is the tube thoracostomy, ICD tubes filter, intercostal chest drainage tubes. There are various sizes of the tube. Usually in adult will go for more than 28 size French ICD tube. So this is the intercostal tube drainage procedure done. So it will be done mostly in the triangle of safety, which is bounded by the pectoralis major, apex of the axilla, and below by the nipple. So here the ICD tube will be inserted and will be connected to an underwater seal or drainage procedure. Underwater seal is needed because it creates the negative pressure so that the air in the pleural space will be sucked to the ICD bag. Then the ICD tube is placed after a blunt dissection from the skin to the pleural space. The pleural space, the ICD tube is placed and it is positioned by the skin sutures. And this ICD tube movement, column of air movement need to be checked, and any collection or any pus or fluid in the pleural space, if it is there, it will be drained into the ICD bag. Thereby, we can manage the patient. We can see if the patient going for any complication or not. If the air column persists in the ICD tube for a long time, patient would have developed the bronchopleural fistula. So this ICD procedure and ICD bag management is most important in the management of the pneumothorax. It helps to decide what the patient needs the further treatment, what to be done, and whether the lung is it helps the lung to expand immediately, which can be seen in the chest X-ray. So usually a chest X-ray should be taken immediately after the procedure to check whether the lung is expanded or not. The complication of ICD can be any bleeding during the procedure, any misplacement of the ICD, which may occur more rarely into the liver or spleen or any other displaced organs. So secondary pneumothorax, even a small secondary pneumothorax may cause respiratory failure. So that all patients require treatment intercostal tube drainage. So ICD tube are inserted in the either in the 4th, 5th or 6th intercostal space in the mid-axillary line connected to an underwater seal. If intercostal tube drainage fails, then thoracotomy with shaving of blebs and pleural abrasion is indicated. If surgery is contraindicated in that patient, then fluorodesis should be done with the intrapleural injection of the sclerosing agent. So tension pneumothorax. Tension pneumothorax is always a medical emergency. A large bore needle is inserted into the pleural space through the second intercostal space. The needle should be left in space until a thoracostomy tube can be inserted. Tension pneumothorax need immediate management. There is no point to observe the patient if it is a tension pneumothorax. He can go for deterioration because of the circulation collapse and he can go for death. So always first itself a needle should be inserted into the pleural space to drain the air immediately. Then the ICD tube should be inserted. Thank you.